Dear students, I am Shadlinska Ramida from Department of Child Dentistry. I welcome you on our 5th lecture, Treatment of Dental Alveolar Anomalies. As we discussed in our last lecture, one of the most difficult but important aspects of orthodontic management is treatment planning. With the advent of modern fixed appliance system, it is deceptively easy to straighten teeth. The skill of the orthodontist lies in placing the dentition in the optimal position and achieving the correct aesthetic and occlusal result for each patient. This process starts with the clinical examination, record collection, and diagnosis. The next stage is treatment planning, which should ideally be carried out in a formal manner and away from the patient using the clinical data and collective records. It is a two-stage process, initially defining the treatment aims and then deciding how these are to be achieved. Many traits of malocclusion can manifest in the early mixed dentition, and there is often a temptation to begin treatment at this stage. In particular, both arch development or expansion to relieve crowding and growth modification to correct skeletal discrepancy have been proposed by some to benefit from an early approach. Advocates of these early treatment strategies suggest that they maximize growth potential, compliance, and orthopedic change in the young patient, reduce the risk of trauma when maxillary incisors are prominent, simplify any further treatment that may be required in the permanent dentition, reduce the need for extractions, and ultimately establish a more stable result. They can also have a psychological benefit, promoting self-esteem. However, there are disadvantages associated with starting treatment too soon. The overall duration will be extended because almost inevitably a second phase of treatment will be required in the permanent dentition, and this can lead to problems with compliance over the longer term. The original arch form and growth pattern will tend to reimpose themselves following the first phase of early treatment, and the prolonged retention period may be required to maintain any correction during the transition from mixed to permanent dentition. Finally, there is a growing body of evidence to suggest that the treatment result for growth modification will be the same whether carried out in the early mixed or permanent dentition. So the most appropriate time to start treatment aimed at growth modification is usually the late mixed dentition, essentially just before loss of the second primary. The principal aims of orthodontic treatment relate to aesthetics and function. Positioning the dentition within the skeletal and soft tissue environmental for optimal facial and dental aesthetics, achieving a stable and ideal static and functional occlusion. The extent to which these aims need to be considered will vary between a piece of acrylic orthodontic appliances that we consider to use, the patient, the age of the patient, and depend upon the diagnosis. The treatment required to achieve them may range from simple occlusal change to complex multidisciplinary intervention. Nowadays we have a big range of orthodontic appliances, and they classified as removable appliances, which can be taken out of the mouth by the patient, functional appliances, which can be either removable or fixed, and fixed appliances, which are attached directly to the teeth. Also, the orthodontic appliances, according to the activity, should be functional, active, functional, passive, or just passive, or just active. Generally, removable appliances are used for simple tooth movement, such as individual tipping or limited expansion. They can also be used as an adjunct to fixed appliances, particularly during bite opening and molar distalization, or prior to functional appliance therapy to facilitate mandibular postural advancement. Functional appliances are used in the growing patient, often in conjunction with extraoral force, to help correct both sagittal and vertical skeletal discrepancy. Fixed appliances are the most popular form of appliance currently in use today because they can affect complex three-dimensional tooth movements in the management of many different types of malocclusion. Removable appliances are not permanently attached to the teeth and can be taken out of the mouth by the patient. And are the most considered advantages. During the first half of the 20th century, orthodontic practice in Europe was based largely on the use of removable appliances. However, over the past few decades, there has been a significant decline in their use, primarily as a result of more efficient fixed appliances being available and an increase in numbers of orthodontic specialists able to use them. However, simple removable appliances retain a place in modern orthodontic practice, usually as an adjunct to fixed appliance therapy or for use in the retention phase of treatment. In particular, a group of predominantly removable functional appliances used primarily in the management of class 2 malocclusion have enjoyed a considerable resurgence in popularity in recent years. And there is advantages of fixed appliances. They don't need the patient cooperation, used to treat the complicated cases of malocclusion, allow greater range of movement more than removable appliances. Among the advantages, we can name more expensive than removable appliance price. They allow accumulation of food around the appliances. That's why the patients with fixed appliances have more bad hygienical status. They less aesthetic, need for special equipment, and more complicated. If we are talking about advantages of removable appliances, we have to highlight their size, simple design, their lightweight, their good hygienical condition during treatment, low cost. They are more aesthetics because the patient can take it out in a very moment, and they don't need special equipment. Disadvantages are they're not effective with uncooperative patient. They treat the minor cases of malocclusion and they allow the simple movements. A variety of tooth movements can be achieved with removable appliances, either individually or on groups of teeth. Tipping, overbite reduction, crossbite correction, extrusion, and intrusion. Removable appliances are also useful in maintaining tooth positions during retention. And in addition, we can name the new treatment system using vacuum-formed removable appliances. Mostly they used for retention, but also for active tooth movement, and they can develop the active tooth movements. Unlike fixed appliances, which can control the movement of a tooth in 3 dimensions, the force applied by removable appliances is mediated by spring, elastic, or piece of acryl, which can only make point contact with the tooth. As no reactionary force or couple is created, in this situation removable appliances are only capable of simple tooth tipping, and apical or bodily movement is not possible. Tipping can be carried out in mesial, distal, buccal, or lingual directions, with rotation occurring about a fulcrum located close to the middle of the tooth root. For the reaction of teeth already mesially inclined, tipping can be an effective tooth movement, but it is inappropriate for teeth that are upright or distally inclined. Removable appliances are composed of retentive and active components connected together by a base plate. When designing a removable appliance, consideration also needs to be given towards anchorage, ensuring that the desired teeth will move under the active force applied by the appliance. The removable appliances have retentive components. The retentive components, like the Adam clasp or labial arch, they are concerned primarily with sitting in the correct position, but they can also contribute towards anchorage. In these pictures, you see Adam's clasp. Adam's clasps are constructed in 0.7 mm stainless steel wire and most commonly used on the first molars. Also, they can be used on premolars and anterior teeth. The arrowheads of the clasp engage undercuts at the mesial and distal corners of the buccal tooth surface and can easily be adjusted at the chair side to increase retention. The bridge of an Adam's clasp can also be used by the patient to remove the appliance from the mouth, while the orthodontist can use it to attach auxiliary springs or tubes for headgear. Solidant clasp is also constructed in 0.7 mm stainless steel wire, but is used for retention on the incisor teeth. This clasp is activated by bending the U-loop towards the base plate, which carries the clasp back into the labial undercut of the tooth. Ball-ended clasp engage into interproximal undercuts between the teeth and are activated by bending the ball towards the contact point. Plint clasp are useful when using a removable appliance in combination with a fixed appliance. These clasps are constructed in 0.7 mm stainless steel and engage the undercuts on the maxillary molar band. As we have said, the active components of a removable appliance are responsible for conducting the desired tooth movement. They can be categorized as springs, bows, screws, and auxiliary elastics. Springs, as you see here in picture, mechanical principles should be considered when applying a force to any tooth with a spring. It should be delivered at right angles to the long axis of the tooth and through a surface parallel to it. Otherwise, a vertical force is introduced which will tend to displace the appliance or intrude the tooth. It should pass as close to the center of resistance as possible to reduce rotation. Palatal finger springs are constructed in 0.5 or 0.6 mm stainless steel wire and used to move teeth mesially or distally along the dental arch. The incorporation of a helix increases the length of the wire and allows the delivery of lighter forces, whilst a guard wire will protect the spring from distortion. Buccal canine retractors are constructed in 0.7 mm stainless steel. These springs can be used to retract buccally placed maxillary canines. However, when activated, it is mechanically difficult to apply force directly to the mesial surface of the teeth. Z spring is constructed in 0.5 mm stainless steel wire and generally used to move one or two teeth labially. Activation is achieved by pulling the spring away from the base plate at an angle of approximately 45 degrees, which will tend to displace the appliance away from the palate. T-springs are constructed in 0.5 mm stainless steel wire and used to move individual teeth either labially or buccally. Activation is again produced by pulling the spring away from the base plate, and therefore retention also needs to be good. Coffin spring provides a useful alternative to a screw for expansion. This heavy spring is constructed in 1.25 mm wire and activated by pulling the two halves of the appliance apart manually or flattening the spring with pliers. Coffin springs deliver high forces that will tend to displace the appliance, and good retention is important. An active labial bow can be used to reduce an increased overjet by tipping the teeth palatally if the upper labial segment is proclined and spaced. However, a normal labial bow will only allow a small range of activation, and this can be improved easier by increasing the amount of wire in the bow. Screws can be embedded into the base plate of an appliance and activated by the patient progressively turning a key. Screws can be effective for expansion to correct a posterior dental crossbite or for distal movement of the buccal segment. Each quarter turn of the screw activates it by approximately 0.2 mm and therefore should be done by the patient once or twice a week. Removable appliances which screws and which different active springs, very useful during early mixed dentition stage. As you see here in photo, upper removable appliance to correct an anterior crossbite affecting the upper incisor in the mixed dentition. The design includes Adam creeps on the first permanent molars, ball-ended clasp between the deciduous molars, between the primary molars, a modified south end clasp on the upper left incisor, a Z-spring for the upper right incisor, and posterior acrylic capping. And this is the result in 2 months. Here in picture, picture demonstrates the Hawley appliances, which is also very simple appliance and widely using in orthodontic practice. Here we see the 2 finger springs, one to move the right central incisor and the other to move the left lateral incisor if it erupts into crossbite. And here we see the view of the palatal side of the appliance shows the double helical finger springs and Adam clasps on the first primary and permanent molars. Functional appliances are a group of largely removable appliances originally developed in Europe during the late 19th and early 20th century. The majority are designed to correct clastomal occlusion, primarily by forward posturing of the mandible in a growing child. The term functional jaw orthopedics was coined for treatment with these types of appliances, which reflected the treatment philosophy underlying their use. By changing the functional environment of the dentition, structural adaptation of the orofacial tissues would follow, with an enhancement of growth potential, allowing for treatment of sagittal skeletal discrepancies between the jaws. However, regardless of exactly how they work, it is clear that in certain cases, these appliances can affect a tremendous change in the dental and skeletal relationships for a growing child in a relatively short period of time. Functional appliances classified as active appliances, which repose the mandible so that the condyle is forced out of the glenoid fossa, and this is in turn is thought to simulate the posterior superior growth of the condyle. And passive appliances. Passive appliances act by repositioning the musculature associated with the mandible so that the jawbone itself responds by growing to the new equilibrium position. The teeth sit between the tongue on one side and the lips and cheeks on the other. If the balance of this force is altered, tooth movement can result. Simply correcting the sagittal-jaw relationship with a functional appliance can often significantly improve the soft tissue environment surrounding the dentition. Forward posturing of the mandible also generates an intermaxillary force directed between the maxillary and the mandibular dentition. The class 2 component of this force can aid significantly with overjet reduction by simply tipping teeth. In addition, the altered mandibular position is also associated with a variable increase in the vertical dimension, which facilitates eruption of the buccal segments. This eruption can be controlled with the use of capping or pasting within the appliance, in particular, allowing eruption of the mandibular buccal teeth in a mesial direction and distal eruption of the maxillary buccal teeth, which aids in the correction of class 2 buccal segments relationship and also in overbite reduction. Numerous types and designs of functional appliance have been described, each with its own treatment philosophy. In a sense, all of these appliances have similar effects, with the most significant being dento-alveolar change, retroinclination of maxillary incisor, proclination of mandibular incisor, distal tipping over the maxillary dentition, and mesial eruption of the mandibular buccal dentition, and the restraint of forward maxillary development. Combined, these effects will result in the correction of class 2 dental occlusion and increase in lower face height and a clockwise rotation of the mandibula. Regardless of how a functional appliance corrects a class 2 discrepancy, their efficiency at doing this can be extremely useful. There are many different designs of functional appliances, but usually bearing the name of they bearing the name of innovator. Anderson activator. The activator was originally described by Anderson and consisted of a loose-fitting monoblock appliance that advanced in the mandible with lingual flanges. The original Anderson activator was worn at night and had minimal vertical opening. It was based upon the hypothesis of simulating increased muscle activity in the mandibular elevator and retractor muscles to act directly on the dentition through the appliance and load the condyle to allow remodeling and growth. The bionator was originally described by William Balters, and compared to the Anderson activator, the acrylic bulk was considerably reduced to allow increased wear and normal oral function. Frankel system, a series of removable functional appliances or functional regulators, were developed by Rolf Frankel, who lives in German Democratic Republic. Frankel was an advocate of the functional matrix theory of growth, which states that there is no direct genetic influence on the size, shape, or position of skeletal tissues. Rather, bone growth is driven by form and function of surrounding soft tissues. Frankel appliances are designed to change the muscular and soft tissue environment of the jaws and therefore modify growth. This is achieved with the use of wires and acrylic shields to displace the cheeks and lips away from the teeth, as well as encouraging forward posture of the mandible. If you see this video, you can see that buccal shields removed pressure from the cheeks to allow for passive arch expansion, whilst theoretically stretching the periosteum to produce additional bony apposition laterally. Low labial acrylic pads are designed to gently impede activity of the mentalis muscle, though to be an etiological factor in the increase of ridge seen in certain patients. There are 4 types of Frankel appliances or functional regulation have been described for treating Class 2 Division 1, Class 2 Division 2 and Class 3 and anterior open bite. Here you see the functional Frankel regulator for Class 3. Also buccal and labial shields removed pressure from the cheeks to allow for passive arch expansion. Twin blocks also very popular. They are very popular among orthodontic specialists. William Clark originally described the twin block appliance, which is unusual in consisting of separate upper and lower removal appliances that work in unison. Each appliance incorporates a set of bite blocks that in occlusion posture the mandible forwards. They move mandible forwards. The inclined planes of these blocks are set at approximately 70 degrees with the height greater than 5 millimeters vertically to ensure that the patient occludes in the lower block in front of the upper and not on it. Overjet reduction can be rapid with a twin block, and accompanying changes in the vertical dimension usually do not occur at the same rate, so lateral open bite is often present at the end of overjet reduction, particularly where the overbite was originally increased. These open bites can be closed down once the overjet is fully reduced with selective trimming of the upper block to allow eruption of the mandibular first molars or part-time wear of the appliance. The most significant advantages associated with the twin block is the ease with which it can be worn full-time by a patient, and in many respects, this appliance has been responsible for the marked increase in popularity associated with functional appliances in recent years. And you have to remember that twin blocks, among the twin blocks indication, they should be I and B angle no more than 4 degrees, no less than 4 degrees. Protrusion of maxillary incisors, overjet more than or equal to 5 millimeters, and normal and lower angle cases. Here we highlighted the effects of twin block, and most important among them, the I and B angle reduction. Functional appliances work most effectively in growing patients. However, the rate of facial and mandibular growth is not constant during childhood and adolescence and can be affected by growth spurts, particularly the pubertal growth spurt. The onset, duration, and intensity of the mandibular pubertal growth spurt varies between individuals but generally occurs later in boys than in girls. Functional appliances appear to have a slightly greater effects on skeletal growth if treatment takes place during this period. Functional appliance wear can encourage a clockwise rotation effect on the dentition and dental bases, which can lead to an increase in the lower face height and greater vertical rather than sagittal change in chin position. To prevent this and optimize skeletal correction in an anterior-posterior dimension, headgear can be attached to the appliances. The aim is to restrict anterior and vertical development of the maxilla whilst encouraging forward mandibular growth. A number of specific activator type functional appliance systems which incorporate the use of headgear have been developed. Headgear prevent the retroinclination and exert a pull as far forward as possible and prevent the maxilla rotating downward and backwards. Also here, headgear help us to distalize the first molars. Depending which cervical or occipital pull had headgear, you can use in different growth pattern. So headgear help us to growth modification, encourage augmentation, and in space maintenance when we have to reinforce the position of first molars. Among the extraoral orthodontic appliances, chin cup widely used. Chin cup is regarded as the oldest orthodontic appliance for the management of class 3 malocclusion. To assess its clinical effectiveness in prepubertal patients, the orthodontists use it, but the patient should have a very good cooperation with his therapist. The limitation of chin cap therapy in growing children with class 3 malocclusion include long treatment time. Chin cap therapy is recommended to start early in childhood and continue until growth completion. However, it is almost impossible to obtain such cooperation. We have another limitation, is that chin cap therapy shows various responses depending on the facial pattern of the patient. Early application of chin cap force is more effective for correction of skeletal discrepancies. Delaware face mask, in most cases, it's also the therapy of choice for class 3 disorders. The method was described by Delayer in 1971. Treatment consists in applying a posterior-anterior orthopedic force on an anterior facial location through elastic bands connected to an intrabuccal appliances. Delayer face mask is composed of an external appliance and intrabuccal device. There are several types of orthopedic mask. The most classical types has a forehead support connected to a chin cup by metal rods. At the level of the commissural line is welded a hoop to attach the elastic bands. Traction must always be oblique, downwards and forwards. The maxillary shift must always be overcorrected by a few millimeters. Here we see the effect of face mask during treatment of class 3 malocclusion. The elastics attached to the hooks on the intraoral appliances. One of the common dental appliances used by dentists on growing children is the rapid palatal expander. It is used to expand the palate and to correct the occlusion that either has a crossbite or a narrow upper arch. It widens the upper jaw to create space for permanent teeth. RP, or rapid palatal expansion, is usually worn for 6 to 9 months in order to correct occlusion. The American Academy of Pediatric Dentistry recommends correcting crossbites as early as possible when behavior allows. Young children are adaptable and flexible, and the procedure is smooth and easy for them. Since the joint of the upper palate is still non-convoluted, it is much easier to correct at this time. The RP is an expander with 2 bands cemented onto last upper molars. They are connected by a metal screw that is turned dilated to expand the appliance. Follow the orthodontist instruction regarding the turning schedule. Look how it proceeds on video. During the first 2 days, the patient may experience slight headaches and tightness, which is a normal effect. Over-the-counter pain medication will relieve any discomfort, but shouldn't be needed for more than a couple of days. And after expansion, we should have diastema between the frontal teeth, which should be closed in a couple of weeks. Vestibular plates protect dental arches from the pressure of the lips, cheeks, fingers, and different objects. They normalize lips closure, the function of breathing and swallowing, train the orbicular muscle of mouth. Appliances with a grid for the tongue normalize its correct position and prevent excessive pressure on the frontal group of teeth. The usage of functionally acting appliances is effective in the young age. During primary dentition stage, constructive elements of functionally acting appliances include buccal shields, labial bandages, vestibular mantles, limiting grids for the tongue, and etc. There are numerous types of space maintainers available in orthodontic practice. They range from the very simple to those with numerous bands and wires. They can be constructed differently and used in different parts of the mouth. They can be unilateral and bilateral. They should be removable. They can be removable space maintainer or a fixed space maintainer, as you see here in the picture. You see an example of a fixed bilateral space maintainers. The patient here, the 6.5 years of age, the appliance is cemented on 2 first permanent molars in order to stabilize and predict the movement of molars. Here also we see the space maintainer, which attach on the first permanent molar.